Hello, I'm Eric Topol, Editor-in-Chief of Medscape, and I'm really thrilled today to welcome Francis Collins, the Director of the NIH, for a one-on-one Medscape discussion. We've been having, Francis, the most interesting people in medicine, and so it's a real privilege to get you to
so it's a
join
countdown
us.
today.
Well, this is a very auspicious time to get a chance to visit with you, not many weeks after the President's announcement at the State of the Union, and then subsequently the White House Precision Medicine Initiative. So maybe we can start off with that and kind of your impressions of where that's headed.
I think I'm enormously pleased with the President's enthusiasm and excited about where this project now is beginning to take shape and go forward. Precision medicine is obviously an area that you have written a lot about, and I think all of us who are interested in trying to move our understanding of health and disease into this next level can see the potential here. But to have this focus and to have a proposal from the President for significant new resources next fiscal year is really quite a moment.
Now, you've been working on it for many years. What finally broke to, finally to move it in this direction, you think?
I wrote a paper in Nature in 2004 proposing a longitudinal large-scale cohort in the United States to try to track what all the factors are involved in health and disease. Let's say it landed with a loud thud because there was, at that time, problems with practicality that people identified. How much is this going to cost? Do we actually have the ability to collect phenotype information on individuals in any kind of reasonable way? But a lot has happened in those 11 years, and this is sort of now a perfect coming together of opportunities with electronic health records, now a part of the medical care of many people, with the genome sequencing costs having plummeted over the course of time, now down to a couple $1,000s for a complete genome. And with increasing, I think, patient, participant involvement in wanting to take part in things of this sort. Add to that something that you've written a lot about, the increasing availability of really exciting wearable sensors to keep track of the physiology and environmental exposures of people in a way that we didn't really have the potential of doing before. And you can see this taking shape in a pretty exciting way. So the time is right, and I think the President got that. And let me say, it's not just the President's enthusiasm that's driving this. Both parties seem pretty excited about this potential of really putting America into an exciting pathway to understanding things that we haven't really had the power to discern before.
Oh, that's terrific. I know you recently had a two-day workshop at NIH to try to work out some of the details. How do you feel that momentum is coming along to really get into the details of how the initiative will take shape?
It was a very exciting couple of days. We had 85 people in the room, and it was a remarkable gathering of people with lots of different perspectives, including lots of patient advocates, people who knew a lot about technology that's going to be necessary for this, privacy experts, genomics experts, epidemiologists, people who are already running cohorts of various sizes that could potentially be brought together to create this planned million or more strong American cohort study. So it was clear that while everybody identified there's a lot of work to do here, there's a lot of details that we haven't sorted out, and we better get busy on that, the sense of potential was pretty much universal. That was very exciting to see. So now what do? We have put together the beginnings of a process to add real details to what is currently a fairly skeletal plan. And there's a working group of my advisory committee to the director that's going to be co-chaired by Rick Lifton of Yale and Kathy Hudson of NIH. We're right now trying to identify the membership of that working group and ask them to come forward by September with a more significant kind of detailed plan of what we might want to start beginning in October when the new funds we hope will be available. They will be asked to keep going and maybe by the end of this year have more details available. That's a lot of work. I mean, when you start identifying the number of questions, it's a long list. But I think everybody's ready to roll up their sleeves and make this happen. And this is not just NIH. We're working with the White House, as you can imagine, with FDA, with the Office of the National Coordinator for Health IT, all of whom are real partners in this effort and who have expertise to bring to this.
No, that's fantastic. Now, there's some other, around the globe, other initiatives, perhaps not quite as ambitious, but for example, a large one in the UK, Genomes England.
Yeah.
Is there a sense that maybe over time there would be international cooperation to bring these together?
Absolutely. We have a lot to learn from each other. In some ways, the U.S. is a little behind the curve in terms of what other countries like the U.K. have done, or Estonia has a really interesting program.
Sure.
And of course, Iceland's been at this for a while, although that data is not accessible in the way that we hope ours will be.
Right.
China's invested in this kind of effort. We need to learn more about that. Absolutely. There ought to be a great opportunity to sort of develop an international network so that the whole becomes greater than the sum of the parts. I mean, you know, the kind of insights we want to derive here, they depend on very large numbers. Big data is what we need here, because we're looking for correlations that are going to be only discernible if you have lots and lots of events to learn from.
Well, I'm going to go for now from the globe to your origins in Stanton, Virginia. You've come a long way from Stanton, Virginia. I know that you were at University of Virginia, so we share some common threads there. And then the other one, of course, is that we joined the faculty at University of Michigan right around the same time in the mid-'80s.
Indeed.
And I'll never forget, Grand Rounds, your discovery of cystic fibrosis. I think that was in 88 or 89.
89.
Yeah.
August of 89.
I've never been to a Grand Rounds that was more invigorating than when you talked us through your chromosome jumping and everything. And it's all been downhill since then, Francis. I don't know what to tell you. So you went along, of course, with that. And then I think it was in 93 that you went on to the NIH to run the
That's right.
Genome Institute. And then you took a little break from running that, and of course all the progress of the drafting and sequencing the human genome was about a year or so in between of running the...
Just about a year, yeah.
And what did you do during that time?
I was trying to figure out what I wanted to do when I grew up. So part of what I did was to write a book about personalized medicine, which I had really wanted to do, but which, as the guy running the Genome Institute, would have been a conflict of interest. So I had to step away from that to be able to do so. But I quickly got pulled into being part of the science advisory process to the Obama campaign. And then when Obama was elected, I was asked to serve on the transition team along with Harold Varmus to help figure out what might be done at NIH in this new administration. I don't remember much about Thanksgiving and Christmas of that year because it was extremely intense trying to pull all this together. And then I did, with not really expecting it, get this call to come back to NIH in a different role. To serve the president in this administration, trying to lead NIH in an exciting time, but a time that's had its own stresses and strains when it came to the budgetary situation, just given our nation's fiscal dilemmas.
Well, you've been quite a champion for trying to get the budget improved at a very tough time.
And hasn't that gone well?
Including a meltdown and everything else. Is that perhaps the toughest frustration you've had to work with, or what do you think?
You know, my daily experience is kind of paradoxical. The science that's going on right now is so exhilarating, and I write a blog twice a week, and I get to pick from all the things that are happening what I want to focus on a Tuesday or a Thursday. And it's always hard to decide because there's so many things you might point to that are just bursting with potential. So we have that side of the NIH director's experience, and then you have the side of why are the resources so tight, and why are we in a circumstance where a lot of scientists with really great ideas are just missing the cut when it comes to our peer review and our decision about how to fund things, because it's at the worst it's been in 50 years. And particularly for early stage investigators who are just getting started, I really worry about the consequences for the future of our enterprise in this country. If we don't do something pretty soon to turn that corner, we're going to lose a significant fraction of those investigators who just basically give up after a while.
Oh, sure.
And that will be a terrible and irreversible tragedy for our future.
Well, it'd be hard to imagine someone who could have as much infectious enthusiasm as you with Congress and the people that are coming up with the funding to take NIH to a higher level. So hopefully, maybe the precision medicine thing will start to get a jump on this? I don't know. What
I
do you think?
think it has captured a lot of imagination. I should have mentioned that precision medicine, besides that million-strong cohort, has another very significant component focused on cancer, which is much more immediate and short-term, to basically take what we're learning about the ability to do dissection of individual cancer genomes and understand what that means about the kind of therapeutic that you'd want to choose. So this is right up front going to roll out rather quickly next year to expand those efforts, to look at combination therapies, to understand when resistance occurs, what's that about, to look at liquid biopsies as a way of assessing response to therapy for people with cancer. All of that has immediate potential, and I think the Congress is also pretty excited when they hear about that. Yeah, I've never, frankly, in 5 years as NIH director, I don't remember a meeting with a member of Congress where at the end of the meeting I felt like it went badly.
Right.
I mean, the evidence is so compelling for the value of what we're doing, for medical benefits, for the economy, for American competitiveness, on whatever sort of theme you want to go. We have a great story to tell.
Oh,
and
it's
people
incredible.
get that.
Yeah, the return on investment figures are just staggering
They
in a
are,
positive way.
indeed,
Wow.
indeed.
Yeah.
So there's no question about bipartisan enthusiasm. The problem is medical research has kind of been caught as an innocent bystander in this unresolved national debate about what we're doing about federal funding of everything. And medical research, oddly enough, is part of the discretionary budget, although it doesn't seem from many people's perspective that that ought to be discretionary. It is. And over the last 12 years, whenever we got into a pickle, it's the discretionary budget that seemed to get whacked. And so we have lost 22% of our purchasing power for research since 2003, just at the point where all this potential is just emerging.
Yeah, well, I mean,
it's so compelling.
you've emphasized this about the most exciting time in science and medicine, and you'd hope that we can really leverage that opportunity more. So let's go fast forward, and let's say that, you know, we can, through your leadership, continue to get the support that's needed. Where do you see medicine, let's say 2020? What are some of the changes that we'll see in 5 years, you think?
Well, you and I both know it's tough to make these predictions, and you've stuck your neck out a few times, and I guess I have too, making them. And sometimes I've been right on the money, and sometimes I've underestimated the pace. I think there's that first law of technology that says when something emerges that has potential groundbreaking opportunities, we tend to overestimate the immediate impact and underestimate the long term. I think precision medicine is probably in that category. The question is, where are we? Are we talking about the short or the long term? I do think over the course of 5 years, particularly for areas like cancer, we are going to see a complete transformation in the way in which that disease is diagnosed and treated, and that's a good thing. And this will be something that will disseminate itself widely across many different medical centers, not just located in a few that are doing high-tech research. In terms of the precision medicine approach to monitoring health for all of us, I mean, you've written cogently about the remarkable curve we're on in terms of the number of available gadgets that we could tap into.
Right.
And using that for medical care is a momentum that's unstoppable. What we have to be sure, and I'm sure you'd agree with this, is that we don't just get excited about all these apps. We actually demonstrate in a rigorous way that they improve outcomes.
Well, you've done a great thing with this big data to knowledge initiative, because we're going to be generating data. In fact, the data seems kind of homeless because it's not going to be an electronic medical record, and you've got terabytes that you can come from not only sequence and sensors and everything else. Is this really the limiting step, would you think, besides obviously the funding you've discussed, is being able to deal with this massive amount of outpouring of data?
That's certainly one of them, and having now recruited Phil Bourne from UC San Diego to serve as my new Associate Director for Data Science, it's great to see the way we're now tackling that in a substantive way, whereas maybe 2 or 3 years ago, people were really worried, do we have a plan here? At least now we can see a lot about what needs to be done. We've got to get it done. And Phil's idea of basically generating a mechanism for a data commons to emerge, where all of these data have a way and the metadata that goes with them to find into a formatted form where you can actually compute on it, that's going to be critical. But of course, having all of that is not a substitute for having smart people who know what to do with the data.
Sure.
So another part of BD2K is to try to nurture the training process. I think there's a lot of talent out there that wants to get into this space, but we have to be sure we give them the right skill set to do so credibly, and we get the right questions addressed and not things that don't matter so much. It's going to be interesting to see how that plays out.
No question. So do you think medicine will be evolving as a data science? That's what some thoughts are about that.
I think so. I think biomedical research as a whole is increasingly in that space, and the practice of medicine needs to be. I mean, we all want to get to a place where patients are fully engaged in their own care. They're going to be dependent upon the kind of data science that is accessible and understandable. Physicians basically want to deliver evidence-based medicine whenever they can, and to do so is going to depend on data sets. I do worry about how quickly the practice of medicine is going to be able to change, because we have a long tradition here of being a bit slow about that. But I think patients will drive the process, and physicians who aren't up to that kind of interaction are going to find it harder and harder to have a satisfying practice.
Yeah, wow. Well, when you're going back to, you're back at Michigan, it's 89, cystic fibrosis, and then you go on to neurofibromatosis, MEN, and progeria. Did you ever think going forward now, 25 years, that it would be in this state? We would be where we are today?
Absolutely not.
It's
I had a great time at Michigan, Eric. It's a wonderful place. I was there doing research, teaching medical students, taking care of patients with genetic diseases. I figured that was kind of the path I would be on for my whole career. Getting that call to come to NIH, to become, oh my God, a federal employee, and manage a huge, sprawling, and at that time, very risky enterprise, the Human Genome Project, was really quite breathtaking, and took me a lot of hard decision-making to decide to say yes. But who knew? I mean, anybody who listens to this who's perhaps having their own dreams about their career path, I guess these days, nobody can really plan what that's going to look like. You got to keep your eyes open. You got to be prepared for doors to close and open that you didn't quite expect, and go with it. And what an amazing ride it has been, and what a time it is to be involved in biomedical research here at this moment, where we are able to ask and answer questions that I would not have dreamed even a decade ago were even possible to consider.
Wow. Well, you're a phenomenal inspiration, and it's wonderful to have you to get a little bit about not just your perspective on this exciting time in precision medicine, but also about where your background and how you got on this path. So thanks so much for joining us, Francis, and we really continue to be cheering for you to take on some of the forces so we can really jump forward as the promise actualize the excitement that really is out there in biomedicine. So thank you so much, and you, no question, fulfilled one of the most interesting people in the world of medicine. Thanks so much for joining us on Medscape One-on-One.